Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I would like to welcome our audience to today's event. I am CLL patient advocate Stephen Feldman, member of CLL Society's Patient Advisory Board, a senior support group advisor, and co-facilitator of the City of Hope support group. We are joined today by Laura Zitella, nurse practitioner with the Hematology, Blood and Marrow Transplant and Cellular Therapies programs at UCSF Helen Diller Family Comprehensive Cancer Center. She is also a clinical assistant professor in the Department of Physiological Nursing at the University of California, San Francisco. I'd now like to welcome Laura Zitella.
Welcome to the CLL Society webinar, Treatment for CLL, When is the Right Time to Start? My name is Laura Zitella, and I'm a nurse practitioner in hematology at the University of California at San Francisco, and I'm delighted to join you today. So let's start by talking about what is CLL, SLL. This is actually the most common adult leukemia, and is a cancer of B lymphocytes, which results in ongoing growth and accumulation of abnormal B lymphocytes. So what are B lymphocytes? B lymphocytes are a special type of white blood cell that help protect you from infection. And under normal circumstances, you have trillions of different types of B lymphocytes because each one can fight one type of infection. So you need to have trillions of unique and different B cells to protect you from any infection that you might encounter. And what happens under normal conditions is when an infection or germ enters your body, those B lymphocytes, the one B lymphocyte that matches that infection, will copy itself and make an entire army of itself to help treat that infection. And once the infection is treated, then those B cells die off, and except for just a couple that remain as memory cells. So what happens with CLL and SLL is that something goes wrong inside the cell, and it starts making copies of itself when it doesn't need to. So there's an abnormal growth, and these cells also live longer than they should, and so it accumulates. And the areas where these cells accumulate are in the peripheral blood, so in your blood, the spleen, which is an organ right under your left rib cage, the lymph nodes, and in the bone marrow. So CLL and SLL are the same type of cancer, but we call it CLL when most of the cancer cells are found in the blood and the bone marrow, and we call it SLL when the cancer cells are mainly in the lymph nodes and spleen. Now, that being said, people who have CLL can also have enlarged lymph nodes. So that's one of the things that we look out for, and I wanted to show you where lymph nodes are located in the body. Lymph nodes are in almost all areas of your body. The ones you can feel the best are here in your neck, but you have lymph nodes that are in the chest, lymph nodes in the abdomen, lymph nodes in the arms and in the legs. And these lymph nodes are all connected by lymph vessels. And lymph vessels are sort of like veins and arteries, but they carry fluid. And I like to think of it as the lymph nodes are a filtering station. So as fluid travels throughout your body, if there are any microbes or any germs, because you've acquired an infection, those lymph nodes sort of dot the lymphatic vessels and act as filtering stations so that the B lymphocytes can respond and make an army of itself to fight an infection. So I wanted to show you where lymph nodes are located, because one of the things that you look for when you have CLL or SLL is if you're developing swollen lymph nodes. And these pictures here show some of the places in the neck and under the chin where you can get swollen lymph nodes. And the picture here shows a man who has a swollen lymph node that's actually not very large, it's noticeable, but that size of a lymph node would not necessarily need to be treated. So how do we diagnose CLL or SLL? Well, most of you watching this probably already have the diagnosis. And so you might know that most people don't have any symptoms at all when they're first diagnosed. Usually what happens is you go and you see your healthcare provider and they draw a sample of blood and they notice that the white blood cell count is elevated. And then there's a total white blood cell count in the CBC. And then there's also a breakdown of neutrophils and lymphocytes. And CLL, SLL is a cancer of the lymphocytes. And so you'll see the total white blood cell count be elevated as well as the absolute lymphocyte count. So the diagnosis is usually by peripheral blood. This is the most common. And when your healthcare provider notices that you have an elevated white blood cell count, they'll send another special blood test called flow cytometry. And flow cytometry can look for certain proteins on the cell surface and can identify a group of cells that all look alike and have the same combination of proteins on the outside of the cell. And that identifies it as CLL. Now, in other cases, other biopsies may be done. For example, if there is a swollen lymph node, a lymph node biopsy might be done to make a diagnosis of SLL. There's also a test called a bone marrow biopsy, where we look in the bone marrow and take a sample of the bone marrow to look for CLL or SLL. But a bone marrow biopsy is not needed to make the diagnosis. And so this is not done for every patient. So CLL does not need to be treated right away. In fact, CLL is unlike many other cancers because it grows very slowly. And some people might never need any treatment at all. And most people won't need any treatment for months to years after they're diagnosed. A lot of studies have been done trying to understand CLL, trying to figure out the best treatment. And one of the multiple studies have been done looking at what happens if you start treatment early. If you start treatment right when someone is diagnosed. And what we've learned is that it does not lengthen the amount of time that you live with CLL. So starting treatment early does not prolong life. And in fact, depending on the treatment, if you start treatment, you can have some unwanted side effects related to the treatment for the CLL. So the general approach to CLL is not to start treatment unless you have symptoms that are affecting your life or affecting any function of your organs, like your bone marrow or your kidneys or your liver. So if there are no symptoms and you feel well, it's really better to avoid taking a medication that might have side effects or be costly or be inconvenient, having to take pills every day or coming into the clinic. Another important factor is that there might be better treatments in the future. I have been working in hematology for 30 years, and I've seen amazing advances in medicine. And the treatments for CLL that we have today, we didn't have those when I first started working with people who have CLL. So I expect that we're going to continue to do research and there'll be even better treatments in the future. So when you're first diagnosed, if you're not going to start treatment, then what do you do? We call it active surveillance. So we're actively monitoring the disease. We're actively discussing your symptoms with you, and we're actively watching the labs. So active surveillance is the period of time after you're diagnosed, but before any treatment is needed, or after you have a treatment, it's the period of time after treatment when you're not on any treatment at all, and we're monitoring things. So what this looks like is routine visits with your healthcare provider. And depending on your situation, you and your healthcare provider will decide how often you need to have those visits. Sometimes it's every month, sometimes it's every 3 months. And what you do with these visits is your healthcare provider is going to do a physical exam, paying particular attention to the lymph nodes and to the spleen, because those are places that can be involved with CLL. A review of symptoms, so how you're feeling, and looking at lab tests. You might be wondering, is there anything I can do during active surveillance? Well, there are a lot of things that you can do. One of the more important things is to stay up to date on your vaccinations. And the reason that is important is because CLL causes your immune system to not function 100%. So there's some level of immunocompromise, meaning that you can get infections more easily. So any vaccines that you're eligible for are good because they'll help prevent infection. Some other things you can do is make sure you're living a healthy lifestyle. Regular exercise is important. Getting at least 150 minutes of moderate exercise every week with some strength training. Eating a whole food diet, meaning eating foods that are natural and are real foods, and minimizing processed foods. Maintaining your emotional health. This is very, very important. And we'll talk about some of the ways that you can do that. Avoid smoking. Another thing is checking a vitamin D level. There is some early research looking at the relationship between vitamin D and overall survival in CLL. And it looks like if your vitamin D level is low, it would benefit you from taking a vitamin D supplement to replace that low vitamin D. And then you can also talk to your healthcare provider about clinical trials and see if there are any clinical trials that are available. There are some trials now looking at starting treatment for CLL earlier because the treatments that we have are more effective than the chemotherapy that we used to use CLL. So that might be something that you're interested in. How will my healthcare provider determine when it's time to start treatment? Well, this is a really big question, and we start talking about the possible treatment options right at the beginning so that you have time to think about it, ask all of your questions, and when the time comes, you feel you're prepared. But we really don't have to start any treatment unless you have symptoms that interfere with your daily life. So for example, if you have severe fatigue, not that you're tired a lot, but severe fatigue that disrupts your daily activities and makes it hard to do your daily activities. If there are drenching night sweats where you're waking up and the bed sheets and your bedclothes are soaked through and through, and this happens every night for more than a month. If you start losing weight, even though you're not trying, and you lose at least 10% of your body weight over 6 months, if you start having fevers and there is no infection, some of those symptoms, these are constitutional symptoms that are related to CLL and that warrants treatment. Other findings would be an enlarged liver, an enlarged spleen, or very enlarged lymph nodes. So not the size of the lymph nodes that I showed you in that picture earlier, but much larger than that. We also look at the laboratory tests. If the absolute lymphocyte count is rising quickly, like for example, if it doubles over a period of 6 months, that might be time to talk about starting treatment. Or if the CLL is causing you to become anemic and have a low hemoglobin level or a low platelet level. Platelets are the cells that help your blood clot. And so having a low platelet level puts you at a little bit higher risk of bleeding. So when we see the platelet count drop, that is time to start talking about treatment. If you start developing repeated or prolonged infections, that is a sign that the CLL is affecting your immune system's ability to protect you from infection, and that can improve when you start treatment. And then lastly, you can get autoimmune cytopenias. So what that means is that you have an antibody against your red blood cells or against your platelets, and it's causing a low hemoglobin or a low platelet count. You don't necessarily have to start CLL treatment for that, because we can treat that with steroids or a medication called rituximab. So if those treatments work for you, you don't need to necessarily treat the CLL, but if they don't, then treating the CLL will help correct autoimmune low blood counts. But I really want to make the important point here that your health, the relationship between you and your healthcare provider is really a partnership. And deciding when it's time to start treatment is going to happen in collaboration with you. So shared decision making is a partnership with your healthcare provider where we help you understand all of the available treatment options. And we give you the benefit of our experience, we give you advice, we talk about the likely benefit, and we talk about the potential side effects. But you help us understand what matters most to you. We want to know what your preferences are. We want to work with you to select the best course of action. So it's always a discussion and it's always a partnership. So for example, if you are feeling fatigue and you're talking about, well, is it time to start therapy for CLL now because I'm feeling tired? It's hard to, fatigue is a very common thing to feel, and there are a lot of reasons to feel fatigued. Like for example, if you have a low thyroid level, that could be an explanation for it. So your healthcare provider will run some tests and determine if the fatigue is due to some other correctable condition or if it's due to the CLL. And then you can work together to decide if it's time to start treatment. I really like this graphic because the whole point of shared decision making is combining perspectives. So the healthcare provider's perspective and your perspective. And we can help you by teaching you about the guidelines, what treatments are recommended to start with, what treatments are recommended if the CLL has already been treated and now has recurred again. We can give you the benefit of our experience with working with many people like you. We can talk about the clinical research and what the goal of therapy is. But we want to hear from you about your lifestyle, what treatment is going to fit in, how can you live as long as possible and as well as possible with CLL. We want to know about your values and your preferences and what resources you have, how able you are to come into the clinic frequently, and your personal goals for treatment. So all of these play a very important role in determining which treatment to start with when you are ready to start treatment. There are the two most common treatments for first-line therapy for CLL are BTK inhibitors, which are pills that are taken indefinitely. So you take these pills every day and you continue until the pills don't work anymore. And when people choose this option, it often works for many years, 7, 8, 9, 10 years. They're very, very effective medications, but it does mean taking pills for an extended period of time. Another option is venetoclax and obinutuzumab. And venetoclax is a pill, and obinutuzumab is an IV infusion. It's a monoclonal antibody that attaches to a protein on the CLL cell to destroy it. And this treatment requires many more visits to the clinic because you have to get the IV infusions. The obinutuzumab infusions are given, initially they're given a little bit more often during the first month, but after that it's monthly for 6 months, and the venetoclax pills are given for a year. So this is what we call a time-defined therapy, where you're on therapy for 1 year, but then you're off therapy for a period of time. And that period of time usually lasts for several years. So when we talk about these treatment options, like some of the things to think about when you put together your list of questions as you're getting ready for your appointment with your healthcare provider is, what kind of response do you think I'm going to get to this from this treatment? What is the benefit going to be? How long do you think the CLL will be in remission if I do option A or if I do option B? And then what are the potential side effects? Like, what are the things I might experience that we'll have to manage? It could be something like a rash or diarrhea, a headache. And we have a lot of things that we can do to help manage side effects, because the goal is for you to feel as well as possible while you're on this therapy and living well with CLL. And then the logistics. As I mentioned, the venetoclax and obinutuzumab means that you have to get some IV infusions. So do you live close to the infusion center, or is it 2 or 3 hours away? And logistically, what is going to fit into your lifestyle? Convenience is an issue. Some people might find that it's more convenient to take pills to treat their CLL. And then cost, unfortunately, is something we always have to consider. There's not only the cost of the medication, but the cost of taking time off work, the cost of driving to the clinic, or maybe even having to stay in a hotel close to where the clinic is. So there's a lot of considerations depending on your situation. Can anything be done to improve my symptoms? So this is assuming that you're not on any therapy at all. And I think it's really important during the time of active surveillance that you consider keeping a symptom journal, because that will help you recognize any patterns in how you're feeling. It's also really important that you let your healthcare provider know if your lymph nodes are suddenly getting bigger quicker. If you start having worsening fatigue that's disrupting your daily activities, if you're feeling short of breath, if you have a decreased appetite, or when you eat, you feel like you get full really easily, because sometimes that can be a sign that the spleen is getting enlarged, because the spleen is under the left side of the rib cage. And when it gets big, it can kind of press on the stomach. And when you eat, that makes you feel full easily. If you have any new pain anywhere, if you have persistent fevers, even though you don't have an infection, if you start getting frequent infections, or if you've drenching night sweats. What is cancer-related fatigue? It's the physical and emotional exhaustion that's related to CLL or its treatment. And this is not just being tired. It's not the type of tiredness that improves with rest or sleep. It's a lack of energy that doesn't improve with rest or sleep, and it limits your usual activities. So what can you do? Well, you can exercise, you can be in nature, you should have a healthy, balanced diet. You should conserve your energy by prioritizing what's important to you and making sure that you schedule those things during a time of the day where you have the most energy. Sleep hygiene is really important. We're going to talk about that on the next slide. I think it's also really important to learn to accept help so that you have the energy to do the things that you want to do, but you allow people to help you with the things that they can to take some of the burden off of you. And then lastly, relaxation techniques can be really helpful to manage cancer-related fatigue. So sleep hygiene. Sleep hygiene is a very big issue. Many of us have sleeping difficulties. And so some of the pro tips for helping improve your sleep quality is to try to go to bed and wake up at the same time every day, even on the weekends and holidays. Getting into a consistent pattern really helps. Also, avoid taking naps if you can. And if you do take a nap, it should be a short nap of 30 minutes or less, and avoid taking naps after 3 p.m. because you don't want to lose that drive to go to sleep when it's bedtime. Sometimes it helps if you take a warm shower or bath about an hour and a half before you go to bed. A hot bath will raise your body temperature, um, but then after you get out of the bath, your body temperature will drop. And that drop in the body temperature can help signal that it's time to go to sleep. Keeping your bedroom cool, dark, and gadget and TV free. You really shouldn't do anything in your bedroom except for sleep and have sexual relations. So we don't want people watching TV or playing with their phone because that really impairs the ability to fall asleep. Limiting caffeine after 12 p.m. can help. Avoiding exercise within 6 hours of bedtime, and establishing a relaxation routine when it's time to go to sleep. So some of the relaxation techniques that might be helpful for you, one of the best ones is simply breathing. Breathing can really calm your nervous system and induce a state of relaxation. And there's many, many types of breathing techniques. One of them is belly breathing, which is simple. You just take long, slow, deep breaths, and your abdomen rises and falls while you're breathing. Another one is called 4-7-8 breathing, where you inhale for 4 seconds, hold your breath for 7 seconds, and exhale for 8 seconds. A body scan can be helpful, and that is where you lay quietly and focus on one part of your body or group of muscles at a time, and then mentally release any physical tension that you feel there. Guided imagery can be really helpful. This is where you think about soothing scenes, places, or experiences that help you relax and focus. Mindfulness meditation. This is a relaxation technique where you focus on what you're feeling in the moment. And when your thoughts drift, you just keep bringing your thoughts back to focus on the present moment. Other things that can be helpful are yoga, tai chi, qigong, and you may have some other relaxation techniques that work well for you. Now, typically, lymph nodes are not painful, but if you do develop painful lymph nodes, you should let your healthcare provider know. And sometimes using warm compresses or resting can help. Acetaminophen is also an option after you discuss with your healthcare provider to make sure that that's an appropriate medication for you. Weight loss related to lack of appetite. If you're struggling with a lack of appetite, it's really helpful to eat small, frequent meals. It's hard to eat a lot of food in one sitting when you don't have an appetite. So you can get in the calories that you need by eating small, frequent meals like every 2 to 3 hours. It also helps to eat food that's high in protein and healthy fats. And so I've listed some ideas here. Nuts, seeds, trail mix, and nut butters are excellent sources of calories and protein and healthy fats. full-fat Greek yogurt or full-fat cottage cheese, beans, bean dips and hummus, avocado or guacamole, oats or granola, eggs, and fatty fish. And these are just some suggestions. There's lots of other good ideas too. And if you are struggling, you could also ask for a referral to a dietitian who could help with additional eating hints. Night sweats. If you're having night sweats, make sure that you have a very cool sleep environment and you're wearing very lightweight, breathable sleepwear, and that your bedding is lightweight. It can help to have fans or a cool, well-ventilated room. You can consider taking a shower before bed because the same as we mentioned earlier, a shower will initially increase your body temperature, but when you get out of the shower, there will be a drop in your body temperature and that can help. Consider a cool gel pillow. Practice relaxation techniques to promote calmness and reduce stress. Avoid stimulating activities or screen time close to bedtime, and try to stay really well hydrated throughout the day and maintain a healthy weight. So in summary, CLL is not like many other cancers because it grows very slowly. And some people may never need treatment, and most people will not need treatment for months to years. Your healthcare provider is a partner in your care, and together you will decide when to start treatment and which treatment is best for you. People with CLL are at increased risk of infection, and it's important to protect yourself by staying up to date on immunizations. The CLL Society has a lot of really helpful information, and these are some links to some of the content that we talked about today. Thank you.
That was an excellent patient-friendly presentation on this important and often confusing topic. So thank you very much, Laura. Okay, we're going to begin answering audience questions and try to get to as many as possible. Unfortunately, due to the time constraint, we're not likely to be able to get to every question. So please email our Ask the Expert email address after this event, and we will share that email address on our closing slide. Here we go with question number 1. When is the right time to begin treatment when on watch and wait? And just a reminder to our audience that watch and wait is synonymous with active surveillance.
Hi, Stephen. It's so nice to be here this morning with everyone. So as we talked about in the presentation, there are some guidelines that have been put together on when is the best time to start treatment, but those guidelines vary a little bit, and we really take into account the individual person. So I saw in some of the chats people asking about like a certain white blood cell count. So for example, a certain white blood cell count does not indicate that you need to start treatment. You can have a white blood cell count of 60,000 or 100,000 or 150,000, and you might not need to start treatment just based on the white blood cell count if you don't have any other symptoms. So really what would be an indication to start treatment is if the CLL is making you feel bad in some way. If it is determined that it's the CLL that's responsible for really severe fatigue or drenching night sweats, where you wake up every single night and you have to change your bedclothes or your sheets, persistent fevers, if the CLL is causing anemia or a low platelet count, if you have a really large spleen that maybe is pressing on your stomach, making you feel full easily, or really large lymph nodes. And the guidelines, like for example, say that your lymph nodes should be at least 10 centimeters if you have enlarged lymph nodes. That's really big. That's like the size of a grapefruit. So mild enlarged lymph nodes aren't necessarily an indication to start treatment either. So really, I think what's important is that you feel comfortable with your healthcare team and you're able to have these discussions with them and talk about what is best for you.
Great, thank you. I'm going to try and combine the next three questions because they're kind of similar. So if you can discuss again the pros and cons of starting treatment early when you're on active surveillance, and might high-risk CLL patients benefit by starting treatment early? And then lastly, is there a criteria for determining a tipping point in symptoms when they've arrived that would signal time to start treatment?
Well, it's important to keep in mind that CLL behaves differently in different people. And most of the time, CLL is very slow growing. And so it's something that you can live with. And if it's not causing you any symptoms, it doesn't make sense to start treatment because the treatments can potentially have side effects that we talked about. Um, and it's sort of like if it isn't broke, why fix it type of thing, where if you're not having symptoms, why treat something that's not causing you any problems? Now, in other situations, the CLL is a little bit more aggressive. And so it is causing symptoms or it's growing more rapidly. And in those situations, it would be good to start treatment because if the CLL is making you feel bad, then the treatment should make you feel better by treating the CLL.
Great. We often hear that CLL and SLL are the same disease, essentially.
Yes.
One person writes in asking, do their treatment recommendations, are they the same or different, regardless of whether you have CLL or SLL?
Yes, they are the same treatment recommendations with one exception. Some people have CLL that is only involving one lymph node area. And if that is the only spot, like the only lymph nodes that are involved is just one place, you could potentially receive radiation therapy. But that's only used if the CLL is limited to one lymph node area. Otherwise, the treatment recommendations are the same.
Thank you. Many, if not all, CLLers experience enlarged lymph nodes as a feature of the disease. The degree of enlargement varies, and not all enlarged lymph nodes are conspicuous from the outside, like the picture you showed. At what point do new and/or enlarged lymph nodes suggest that it's time to begin treatment?
So as I just mentioned, the guidelines say that treatment of lymph nodes that are more than 10 centimeters, which is about the size of a grapefruit. So that's pretty big. And if your lymph nodes are getting that big in your neck, it's probably becoming uncomfortable. And so you and your healthcare provider might even decide that you need treatment sooner than that. It is Some lymph nodes are conspicuous and some are not. If there is any concern that you might have enlarged lymph nodes that you can't see, sometimes we will order a CT scan so that we can see if there's any enlarged lymph nodes in other parts of the body. I probably would not do that unless there were symptoms, like there was pain somewhere or there was abnormal laboratory tests, like for example, if the creatinine or kidney function was abnormal, I might want to get a CT scan to check and make sure there weren't any lymph nodes in the abdomen that were affecting the kidney function. So I would probably only order imaging if there are symptoms.
Can patients request getting an MRI instead of a CT scan?
They could. I'm not sure why. Sometimes we would do an MRI if someone had kidney problems, and a CT scan has contrast in it. We would want to avoid that. But I would probably order a PET scan if there were kidney problems instead of a CT scan. An MRI, we may order if we were concerned about like central nervous system involvement, or if there was another specific reason, but generally the best imaging is a CT scan or a PET scan.
Great, thank you. All right, I'm going to try and combine a bunch of questions in this next round. Many patients are understandably apprehensive about starting or remaining on treatment for extended periods over concerns of the potential side effects, and side effects are also referred to as adverse events, caused by the medications. How have the side effect profiles of the targeted treatments, CLL drugs, improved over time? And one person, this is more specific, one person wrote in that they've experienced a full body rash and was wondering whether it might be caused from taking Calquence, which is also called acalabrutinib, a type of BTKI, Bruton's tyrosine kinase inhibitor. I know that's a mouthful. The questioner notes a fear of going back on Calquence owing to possible side effects. Would you suggest they discuss with their doctor switching to a different BTKI?
Oh, these are great questions. So all of the BTK inhibitors, the first one that was approved is ibrutinib, and now we have acalabrutinib, and we have zanubrutinib, and we have pirtobrutinib. And with every generation of new BTK inhibitors, we're seeing fewer and fewer side effects because they're more selective and they're more targeted for CLL. So in general, there are fewer side effects with acalabrutinib and zanubrutinib than there are with ibrutinib. So that's one part of the answer. The other part of the answer is that we also have now a lot of experience in managing the side effects. And what we've learned is that dose reductions or holding the medication for a week or two to let the symptoms resolve is very, very effective. And most of the time, that side effect will go away. And then we can restart the medication either at the same dose or at a reduced dose. And most of the time, that side effect does not come back. So we've looked at how people do taking the BTK inhibitors over a long period of time. And what we've seen is that people who have dose reductions because of side effects or have to hold the dose for a little bit because of side effects are generally able to restart it without having recurrence of those side effects. And they have similar overall survival. So they live as long as people who don't require dose reductions. But they live much longer than people who have to stop the BTK inhibitors completely. So for someone who has a really bad side effect like this full body rash, I mean, without knowing how bad it was or seeing it, I can certainly understand being fearful of restarting it. But depending on the situation, it may be worth starting it again and seeing if it happens again. And if it happens again, then stop or consider changing to zanubrutinib. And either option is reasonable to discuss with your healthcare provider.
Great, thank you. Here's a question that comes up pretty frequently. Under what circumstances should someone seek out a second opinion, and what's the best way of going about that?
I think that, so the initial treatment of, there are a couple of reasons you might want to seek a second opinion. You may just want a second opinion because you want the reassurance that you've explored every option. So that would be one thing. Another reason to get a second opinion is if the CLL doesn't respond as you would expect to the initial therapy. So usually with these initial therapies, we see the CLL in remission for 6, 7, 8 years. If your CLL, if you are treated and your CLL comes back in a short period of time, that might indicate that it's just a little bit more aggressive and you might want a second opinion for that. If you've had all of the standard therapies and you're interested in exploring clinical trials, or if you needed a specialized therapy like CAR T therapy at a specialized center, those are other reasons to get second opinions. So to get a second opinion, you could go to an academic medical center where you see a hematologist that specializes specifically in CLL. Rather than a general cancer doctor, or you can go to the CLL Society where they offer a second opinion with a CLL expert that works with the CLL Society. And on the website, well, we'll put the link in there for the website, but that is an option that the CLL Society offers, and it's a free review of your medical records and a video meeting for 30 minutes with a CLL expert to discuss your case.
Great. One of the things that's confounding for patients sometimes is if they get different opinions from two different oncologists. I don't know if we can address that a little bit, but that can be a source of confusion. And maybe you can expand a little bit more about the distinction between a CLL expert versus the local community quote unquote oncologist or hematologist. What makes a CLL expert an expert?
That's a great question. So a community oncologist treats all different types of cancers. So knows a lot about a lot of different cancers, but a CLL expert specializes in CLL. So that means instead of seeing maybe, 5 or 10 people who have CLL per year, we're seeing, 5 or 10 a week, that people who have CLL. And a CLL expert really usually also does research, and so is involved with some of the clinical trials and has experience with new and upcoming medications.
And I'll add that many CLL patients have both a local hematologist and a CLL expert on their team. So you don't necessarily have to rule out one or the other. Having both is ideal.
I think that's a really good point. I mean, I work at an academic medical center and I work very closely with a lot of physicians and other healthcare providers in the community. And I would personally, I would want my healthcare provider to feel comfortable and collegial with other healthcare providers. And so I hope that you don't feel like, we would be offended if you wanted to get a second opinion, or that we wouldn't be willing to work with somebody, because most of us do and should. Like I'm in constant contact with other healthcare providers who, we share the care with.
Thank you. We have a question regarding testing. What are the routine blood tests that patients should receive? What is the role of flow cytometry, which you discussed? And when should patients receive this? And what is the importance of testing before treating?
Okay, there's a lot to unpack there. So first of all, flow cytometry is the first test that you do when you see an elevated absolute lymphocyte count. So I mentioned that in a complete blood count, you'll get a total white blood cell count, And then that total white blood cell count is broken down into neutrophils and lymphocytes and basophils and eosinophils. So all the different types of different white blood cells. And you want to look specifically at the absolute lymphocyte count. And if the absolute lymphocyte count is elevated, you want to know if that is because you have an infection or if it is a malignancy like CLL. So the flow cytometry is done on the peripheral blood, and it can identify whether or not there's a population of cells that have specific markers on it that indicate that you have CLL. So that's done at diagnosis. And then if you're on active surveillance, some of the blood tests that should be done is a complete blood cell count. So that's monitoring the lymphocyte level. It's also monitoring the hemoglobin to see if you're developing anemia. It's looking at platelet count. And platelets are the cells that help your blood clot. So we want to make sure that that is at a normal level and that's not dropping low. We would also look at kidney function, liver function, and LDH. And LDH is an enzyme that's found in every single cell in your body. And it's a very non-specific test. It can be elevated for a lot of different reasons. It can be elevated even with strenuous exercise, any sort of tissue damage, breakdown of cells. But in lymphomas, it can be elevated when there's a lot of lymphoma activity. So we look at LDH because it's typically normal in most people who have CLL. If it was elevated, that would give us a clue that maybe the CLL was becoming much more active, or in very rare cases, CLL can transform from a low-grade lymphoma / leukemia into a higher grade aggressive lymphoma, which would need to be treated differently.
A related question. What information does a bone marrow biopsy provide to the treating physician that they wouldn't necessarily glean from regular peripheral arm blood draws?
That's a good question. So if there is anemia or a low platelet count, and there's a concern that that's not due to CLL, you could get a bone marrow biopsy because that could look for other bone marrow disorders. So for example, there are some bone marrow disorders called like myelodysplastic syndrome, where you are not making enough red blood cells, you're not making enough platelets, and that is a different type of blood disorder, and that is treated differently. So a bone marrow biopsy is not generally done when there isn't any concern for other blood disorders. It's only done if there is a concern that there might be some other blood disorder.
Thank you. When are drug holidays, that is temporarily stopping medication, appropriate for CLL patients? And what are the pros and cons from taking a break from CLL treatment?
That is a more complicated question because it depends which treatment you're on. If you're on a BTK inhibitor, all of the research that we have done to date is that BTK inhibitors are much more effective if they're continued indefinitely. And if you stop the BTK inhibitor, the outcomes are not as good. In contrast to that, if you're being treated with venetoclax and obinutuzumab, then you do get a treatment holiday because that is a treatment that is given for a period of 1 year.
There are occasions, though, sometimes when people have surgical procedures that might require going on a drug holiday for one of the CLL drugs.
Yes. So with the BTK inhibitors, if you have any sort of procedure planned, you do need to stop the BTK inhibitor. And the reason is it affects the way that your platelets clot. So the way your platelets clump together. And so it increases the risk of bleeding if you stay on them when you're having a procedure. So depending on if it's a minor procedure or a major procedure, if it's minor, you hold it for 3 days before and after the procedure. And if it's a major surgery, then you hold it for 7 days before and after the procedure.
Thank you. Tell us what PEMGARDA is. Someone asks, do you recommend PEMGARDA antibody infusion for CLL patients in watch and wait?
That's a really good question. PEMGARDA is a is our antibodies against COVID. And you may remember Evusheld, which when COVID first, which was something that we used to have for an earlier variant of COVID. But the issue is that when you have CLL, sometimes you don't respond very well to vaccines. So the best thing to do to protect yourself against COVID is to get COVID vaccinated. But we would check antibodies in people with CLL after COVID vaccination, and sometimes they didn't mount an immune response, so they didn't have any antibodies, even though they had the vaccine. So if the vaccine is always the most effective way to prevent COVID, but if you don't develop any antibodies, then Evusheld was developed to give you a passive way to give you antibodies to protect you against COVID. But then Evusheld went away, it was taken off the market because the COVID virus mutated and it was no longer effective. So Evusheld is not used anymore. So PEMGARDA just came out and it is thought to be effective against the current variants of COVID. And so it is recommended for people who don't have an immune response to the COVID vaccine. Although I have to say it's very hard to get. So for example, we don't have it at UCSF right now. And one of my patients looked into it and he said the closest center he could find from California was in Denver, Colorado. So I'm not sure when we're going to get it. And I don't know if anyone in the audience has any experience with it. But there's been issues in availability.
Thank you. The next question is again about deciding when to start treatment, but it also is inquiring about how treatment might differ depending on what your prognostics are, your cytogenetics. So the question is, how much weight is given when there are non-favorable markers, maybe like 17p deleted in the blood work, or being unmutated for IGVH?
Those are really good questions. So first of all, before you start any treatment, it is really important to look for mutations in the immunoglobulin heavy chain. And there can either be, we either classify it as unmutated or mutated. And unmutated tends to have a less favorable prognosis, meaning that it is a little bit more aggressive and it tends to recur quicker than mutated. So mutated is more favorable. And then it's also important to do FISH testing. So this is testing of the chromosomes. And there's a panel of different chromosomes that we look at that are associated with CLL. And the least favorable is 17p. And then we also do P53 mutation testing. So these are all very important tests to have before you start any treatment. And the CLL Society has a test before you treat information page that we will make sure that you have the link to. And that has a lot of important information. So how is that used? It's mostly used to just get a sense of how long the treatment is going to work for you, because the available treatments that we have work equally well. I guess what I'm trying to say is that we wouldn't necessarily recommend a BTK inhibitor versus venetoclax or obinutuzumab based on any of those genetic features. Now, that being said, earlier you mentioned that when you talk to different experts, you get different opinions. And that's true in all areas of medicine, because people have different feelings about it. There are some CLL experts that think that if you have less favorable genetic features of the CLL, that maybe staying on a BTK inhibitor is better because you're on treatment for a longer period of time. But that's not a hard and fast rule, and not all CLL experts feel that way.
So there's an art to it, not just the science.
Exactly.
Here's an interesting question. Somebody wants to know how to distinguish between menopause symptoms and CLL symptoms, specifically hot flashes during the day and night sweats.
Yeah, that can be really hard. So with hot flashes, usually you have more flushing and dizziness, and it happens during the day instead of just at night. So that can be challenging to make the distinction.
Someone writes, are there statistics on the recurrences of CLL if after treatment, and they mentioned chemo, if it's been declared in remission?
Yes, there are statistics. I mean, generally with the BTK inhibitors or venetoclax or obinutuzumab, the average time until the CLL recurs again is about 6 to 7 years. And I think I saw in some of the other questions, I had made a comment during my presentation that our goal is that people live as long as possible and as well as possible with CLL. And someone was asking if that means that CLL is fatal or incurable. CLL is considered to be incurable, with the very rare exceptions of doing an allogeneic bone marrow transplant, which is not typically necessary and not typically done in CLL. It is done in certain situations, but it's not usual. So yes, it is incurable, but it's generally not fatal. And most people will live with it without dying from CLL. That being said, unfortunately, sometimes it is fatal for some people, but most of the time it is not. And then one other correction Liza just brought my attention is I said that localized radiation could be used for lymph node for CLL, but I meant to say SLL. And that's true. I meant to say SLL. So a localized lymph node, if you have CLL, is not treated with radiation. I meant to say SLL.
Thank you for that. Somebody is asking something that's a little bit on the slightly nerdy side about, the EVOLVE study. So not everyone's going to know what that is. And the question is, if early intervention is not usually warranted, why the EVOLVE study? So I guess you're going to have to start by telling us what the EVOLVE study is.
Okay. I'm going to have to see what the EVOLVE study is. Oh, venetoclax and obinutuzumab. Okay. So there are a couple of studies that are looking at early intervention. So I mentioned that at this point, with all the research that we've done, there is no benefit to starting treatment early before you have symptoms. But all of the contemporary treatments, the BTK inhibitors, venetoclax and obinutuzumab, right? They have all been only approved in the last 5 to 10 years. So a lot of the information that we have about starting treatment comes from a time when we use chemotherapy like chlorambucil or other types of treatment. And so there are clinical trials looking at using these contemporary medications, which are more effective, to see if starting treatment early improves overall survival, so it improves how long we live, or improves how long the CLL is in remission. So we don't know the answer to that. And that's why we're doing clinical trials, is to find out the answer. And so if that's something of interest to you, then I would highly encourage you to enroll in a clinical trial. And maybe we'll learn that starting treatment earlier is better, but maybe we'll learn that even with our new medications that work so well, starting treatment earlier doesn't improve outcomes.
Thank you. You mentioned in your presentation about vitamin D, the importance of vitamin D. Someone writes in, how much vitamin D is recommended for a 53-year-old female? And I know there's not a consensus on how much vitamin D, and even if it's efficacy, if you read the news, there's often some confusing information about that. So take it away on vitamin D.
Oh my gosh, that is a really hard question to answer. So I can only offer my opinion. There is a lot of conflicting research on vitamin D, and it's important to think about cause versus correlation. So low vitamin D levels are associated with a lot of different medical conditions, but we don't know for sure if correcting the low vitamin D helps with those medical conditions, or if it just happens to coexist with them. So there is no certain recommendation for how much vitamin D a person should have. If a vitamin D level is checked and the vitamin D level is low, then it is reasonable, and there's enough evidence that you should replace that vitamin D with a vitamin D supplement. I think it's also important not to overcorrect vitamin D. Like, too little of something is not good, too much of something is not good. And there's also considerations, like there is in the cardiac literature that excess amounts of vitamin D may affect heart calcium levels, which could be associated with more heart disease. So I think it's important to not make a blanket recommendation about vitamin D, but to work with your healthcare provider who knows your medical history and can help you determine what's best for you. And I think that vitamin D supplementation should be based on vitamin D levels.
Thank you. Okay, the next couple of questions may not be in your wheelhouse, but I think they're on everyone's mind. And the question is, are CLL treatment costs covered by insurance? And then someone mentions a little something specific to them. Yeah, the cost is an issue. A year of treatment, protocol, hospital, et cetera, not to mention venetoclax at 14,000 plus a month. It was over $500,000 in 1 year of treatment. So cost, financial toxicity. Is that something you can address?
I wish I had the answer for it. It is real and it is a real issue. And it's with every single cancer medication that's approved. Yeah, it's a big issue. So the costs are covered by insurance, but there still may be copays. And certainly with Medicare Part D, there's the donut hole where there's a period of time where you will incur more costs before there's better coverage. So I think, the CLL Society has some resources. We often will work with the drug companies to help with patient assistance, to help with some of the cost. And yeah, I wish I had a better answer. I think cost is a very important concern, and there are some resources that we can help, but unfortunately, we're not really addressing the root of the problem, which is that the cost of medications in the United States is a lot.
Here's something that's an easier question to answer. And it goes to blood counts. The person writes in, my white blood cell count is 40,000 plus, and my ALC, absolute lymphocytes, are also high at 60,000 plus, yet my oncologist still sticks to a watchful waiting period. Should I be concerned?
If you don't have any other symptoms, I would not be concerned about that. I have many patients who have high white blood cell counts, like 40,000, 60,000, 100,000, that don't require any treatment and have been stable over many years.
Yes, and in the CLL Society, we always say we don't treat based on numbers, and to follow the trend. So if your trend is, it's fairly steady and you have no symptoms, then it might not yet be time to start treatment. Okay, I'm going to read a couple of questions just cold. I haven't read them through. What do we risk by not ever treating CLL? How do we compare the risk to the risk of treatment? The risk of CLL versus the risk of treatment?
So what do you risk by not treating the CLL? If you're not having symptoms, then you don't risk anything by not treating CLL. If you are starting to have symptoms, then you risk becoming, like, it depends what the symptom is. If you're anemic, you risk becoming more anemic, or being short of breath. If your platelets are low, there's a risk of bleeding. So if you don't treat the CLL because you don't need treatment, you're not having any symptoms, then there is no risk to you to not treat it.
Yeah, I hear in that question, the anxiety that many people have. I certainly had it prior to when I started treatment, about how onerous the side effects of treatment might be. I've found in my experience and as in my role as a support group facilitator that most often people's adverse effects from the drugs are minimal. And in my case, I had ibrutinib and Gazyva 7 years ago, and I had virtually no side effects. I don't know if that's common, but I think people's anxiety about starting treatment, they may often hesitate to begin treatment because they think they're just going to be steamrolled by side effects.
Yeah, so I think every step of the way, there's a lot of anxiety. Like there's some anxiety associated with active surveillance and not doing any treatment. And then there's some anxiety associated with the idea of starting treatment and what to expect. In my experience, most of the time, side effects are very manageable. And there are many people like you, Stephen, who experience minimal side effects or no side effects when they're going through their treatment. There are other people that have some side effects, but they look back and they would do it all over again, because either there were dose adjustments made or the side effects were temporary, they went away. So yes, I agree with your perspective.
And a follow-up question from the same patient. Do night sweats come on suddenly and then happen every night, or gradually on some nights, getting more frequent? Can they happen before bed? Is there a fever associated with them?
Yeah, it can be variable. So they can just start every once in a while and then increase in intensity. The technical definition of night sweats is every single night and drenching. So not just a little bit sweaty, for a month or more. So if it's consistently happening every single night for a month, those are real night sweats. If it's happening every once in a while, that might not be something, an indication that you would want to treat that. Usually it happens at night, not before you go to bed. Usually it's something that happens during the night, and it can be associated with fevers. Although, fevers and drenching night sweats can also be due to infection. So if you were having fevers and drenching night sweats, I think the first thing to do would be to see your healthcare provider and, rule out the possibility of infection.
Thank you. Next question about immunizations. The member writes, I've heard others state that vaccinations don't work well with those with CLL. I always get them, but wondering if there are considerations.
Yeah, vaccines don't work as well for people who have CLL. However, they work for many people that have CLL. And even if they don't work as well as in someone who doesn't have CLL, if you get some protection from it, it's worth it. So we recommend that everyone stay up to date on all the age appropriate vaccines. Like, for example, anyone over the age of 50 should have shingles vaccine. If you're over the age of 60, there's an RSV vaccine now that protects against respiratory viruses. It's important to have the pneumonia be up to date on pneumonia vaccine and your tetanus vaccine. So it is a consideration, but we still recommend all the same age appropriate vaccines as we do for people who don't have CLL.
And here's a related question. As a parent, there are some live vaccines given to children. What is the recommendation from staying away from live vaccines given to loved ones?
Yeah, that's a good question. If you are not on active treatment, that is probably not too much of a concern, especially, um, because your children do need to get those vaccines. But I would talk to your healthcare provider about that.
Okay. Someone asks, would lymph massages or bouncing on a rebounder be helpful?
I wouldn't expect any manipulation of the lymph system to affect CLL.
Another question. Have you come across anyone taking green tea extract for CLL? My 35-year-old daughter has CLL since 2020. She was 32 at the time, and she takes green tea extract. How many years that person has taken green tea extract? Any side effects?
There's some laboratory data that has looked at green tea extract, but that is not currently one of the recommendations, and I am not familiar enough with it to be able to comment on potential side effects.
Here's an interesting question. Are CLL patients more likely to get other cancers and any particular ones?
Yes, that's a really good question. People who have CLL are at higher risk of getting skin cancers. And so we recommend that everybody have a annual skin check by a dermatologist.
Thank you. Someone writes in, would you comment further about autoimmune hemolytic anemia? I've recently heard that this occurs in 10% of watch and wait patients. Outside of a blood test, what do I watch for on AIHA?
The main way to diagnose autoimmune hemolytic anemia is by a blood test, looking at the hemoglobin or hematocrit level. So if you develop anemia, your healthcare provider can do some other tests to determine whether it's anemia from the CLL or it's autoimmune hemolytic anemia. And what the difference is an autoimmune hemolytic anemia, you actually make an antibody that that latches onto the red blood cell, and then your body breaks down the red blood cell. So you basically have antibodies that are destroying your red blood cells. And that is treated with steroids or with rituximab and doesn't necessarily require treatment of CLL, but it is a known condition in people who have CLL.
Is bone density testing appropriate for CLL patients?
Yes, depending on your age, you should have age-appropriate bone density testing.
And the next question goes back to test before treat. And the question is, do you treat CLL differently if you have a 17p deletion? Or I'll insert myself, what treatments should you not get if you have a 17p deletion?
Well, if you have a 17p deletion, you either of the two initial treatments for CLL would be appropriate, either a BTK inhibitor or venetoclax and obinutuzumab. And as I mentioned earlier, some CLL experts would not recommend one over the other if there is a 17p deletion, but there are other CLL experts that think if you have a 17p deletion, that it's better to stay on some sort of continuous therapy. And this is, this is opinion, and not everyone has that opinion.
Okay, this may or may not be our last question, but we're getting close to the end. Treatment of oral meds were discussed at daily until they no longer work, or IV and pills for 1 year. What is the opinion of treatment until measurable residual disease, MRD, or other fixed duration other than the 1 year regimen discussed? So I guess the question is about MRD, how you might use that to determine when to continue or discontinue treatment.
At this time, MRD is not used to determine when to continue or discontinue treatment. So MRD is measurable residual disease or minimal residual disease. And it is there's a couple ways to measure MRD, but both of the ways that you measure it, you can detect like 1 in 100,000 or 1 in a million CLL cells. So that means that the treatment was so effective that when you look in the blood, you can't even find 1 CLL cell in 100,000 or in a million. And we think that if we get such a good response to the treatment, then that translates into the CLL staying in remission for longer. So this is still a question that is being looked at in clinical trials. And at this time, MRD is not being used to determine the length of treatment.
Great. That's going to end the Q&A part. So Laura, do you have any final thoughts that you'd like to share with our audience today?
I just want to echo what the CLL Society always says, which is that it's really important for you to educate yourself and learn as much as you possibly can about the CLL, and use the resources that the CLL Society has available to you to make sure that you are making the best decisions for yourself.
Great, thank you. Okay. Once again, we'd like to thank our generous donors and grant support from AstraZeneca for making this event possible. Thank you, AstraZeneca. Thanks to all of you for joining us today, and a big thank you to Laura for her presentation and helpful responses to our questions. Please complete our event survey and provide your feedback to help us plan for future events. A reminder, this virtual event was recorded and will be available on our website along with the slide deck and a written transcript of the webinar. If your question was not answered, and we had over 100 of them, please send it to asktheexpert@cllsociety.org. Save the date for our next virtual event, Ask Me Anything, with Dr. Richard Furman on July 24th. Please remember, CLL Society is invested in your long life, and you can invest in the long life of CLL Society by supporting our work. Be strong, we're all in this together, and thank you for joining today.